after the delivery that the jaundice came. It may have this as a pathological problem that the baby has. Okay. And so I pass through my hands at the bridge of the nose. Sometimes some of these babies may come with broken nasal septum. So I pass my hand there, and then I try to observe the nostrils, whether they are patent or there may be a nasal polyp as an abnormality which the baby may come with. Okay, so from here I come to the mouth. Over here, I'll use this baby because this baby, the mouth cannot be open. And so I use my little finger and then try to enter into the mouth to feel for the upper floor of the mouth, which may be opened up, where the baby may have cleft palate or cleft lip. The lips may be parted, as well as the upper floor of the muscles. The palate can also be parted. So these are all abnormalities that can be. And then sometimes as you open the mouth and then place your hand there, you can also feel for false teeth, which may also appear in the mouth as a result of extra calcium that is accumulated over there. It's very, very soft and very white. As the baby continues to breastfeed, these false teeth may just dislodge on its own. So this one is not a big deal at all. Then you also look into the ear for any discharges, You hold the pinna, open up a little, and then observe. Both ears would be observed to identify any discharges from the ear. Once it is done, I can check the head circumference to identify if the head is very, very small or above the normal, which is about. So I'll go this way.
They said me I should just let them come and do the. I said it's not the doing that is the problem. Yeah, I can't pack the wardrobe is in.
Place the head and then stretch. So this one I had.
That is the chemical they use to do the tiles. That one
is Isifu. Okay, so I had 39 centimeters as the head circumference. All right.
Ali.
And so from there, then I'll palpate the neck for any swelling. This baby has a swelling on the right side of the neck, but this side, there is no swelling over there. Okay, so as I continue and identify any abnormality, I will spell it out.
Can I even go to Namolofino and leave them here?
Then I come to the upper extremity. So over here, I bring the hands together to check for equality of the limbs. And once I'm satisfied with the length of the upper limbs, I'll cover one side and then examine. So I will touch the upper arm from the shoulder over here to look out for if there is any fracture or any dislocation. This baby will give a very sharp cry. Okay. So with this, I try to open up. You realize that the baby has clamped the hands together, so there is an abnormality over here. Whilst if you look at the other hand, it is opened up. So you can see the difference. So this one too, I will touch, and then I'll open the palm. So over here we have the palmar creases, and then the fingers are 5. 1, 2, 3, 4, 5. They are opened up, and so there is no abnormality with the left hand. The palmar creases are also well developed. In the case of a preterm baby, you see that it is very, very faint. This one is darkened up. If there is a problem as in trisomy 13 or Down syndrome, you see that the baby will have only one palmar crease stretch out, very long one. Yes. And so these are all abnormalities that are detected as we examine the baby. Then you palpate the clavicular bone, superior and then the inferior part, to identify any structure whatsoever. Then you do some palpation at the breast.
Go and sleep.
However, you don't have to squeeze. Sometimes some mothers, when they go home, they will squeeze and then they will feel that there is some a swelling over there. They will press, and by the third day, the whole chest will be swollen up because that thing has been punctured and there is an inflammation, which is leading to a lot of collection of pus, causing the baby to have rise and fall of the temperature. The temperature will rise. So when you reach here, then you check out for
Please, Abigail, and not.
and once
We are
we are satisfied that this one is okay with us, let's continue, and then I'll check the temperature of this baby. In the armpit, it's supposed to be for 2 minutes. It's supposed to be for 2 minutes. And then, formerly, when we were using the other thermometer, you can also do a mouth thermometer or gun thermometer. That one is an instant one. I forgot even to bring that one. We have it. The next time we'll do that. And so we want to check and find out if this baby has a normal body temperature or not. So as we move on, we expose, and then I'll come and then palpate the abdomen for any tenderness, any swelling, and any distension. The abdomen may be bloated up. And then when we reach here, we check the cord. If the cord is, and so this is the baby's cord, which has been clamped at delivery. And so you observe if the cord is bleeding or not bleeding before you do the care. So with this one, I'll do the care when I'm done with the examination of the baby. But this time, because we palpated the abdomen, we take the opportunity to observe how the cord is behaving. Okay. And so there is no bleeding. We have an extra cord clamp if there is bleeding, we will do the reclamping that is above the first clamp, below the first clamp. And then we don't cut, we leave it over there as we clamp. So we move to the lower extremity. So over here, this baby is a female. So we will observe the vulva. And then we make a little part to look out for the clitoris, the urethra, sorry, the urethra, and labia majora minora to observe everything over there before I'll come. And then if this baby were to be a male, we hold the penis, and then you look out for the prepuce, you pull it backwards, and then you look out for the opening of the urethra, whether it is centrally situated, posteriorly or above, so that if there is any abnormality over there, then you know how to educate the woman before circumcision is done. And so with this, you look at the lower limbs, you see that it's not equal. One is short, one is long. Okay, so this one, I hold the thigh as I examine the upper extremity for any pain. I do same over here. If there is any fracture or dislocation at the hip, this baby will give a sharp cry. And so we have something we call the Barlow sign. And so you push, sorry. You try to push the thighs inwards. So it will go this way, and then you rotate. So that if there is any abnormality over there, so it's this, you hold the thigh inwards like this, and then you rotate about 2 times. If there is nothing, this baby will just look at you and will not make any noise. But if there is a problem at the hip joints, this baby will give a sharp cry. So that is known as the Barlow sign. If it is positive, this baby will cry. No cry means that it is just the normal hip. Sorry.
Let's say, yeah, dear 10 cities.
They say, bro.
Yeah, now they're 10.
They say, I have more than 7 cities. Because $1 is around like 11 to 14 cities.
Okay, so we move on.
This is about making money.
So you see that.
Mute yourself.
I said Adrian. Oh, better because I'm going to give you Johnny fresh.
The
Labels, what is that?
toe
Glasses, what is that?
is
Sister Gloria Bona, please mute yourself.
are webbed together. And if you come to the left leg, all the 5, 1, 2, 3, 4, 5, they are all webbed together. So there is a real abnormality. Together with the knee joint is also flexed. And so as we examine, we want to see now, we have what we call the that's what we'll come to the reflexes when we are done with all these things. Okay. And so we'll turn the baby sideways. Then we examine the back. Let me turn the baby this way so that they can see. Okay, And so I pass my hand over here from the neck down. I pass it through the spinal cord to identify any abnormality. Sometimes there is a spinal bifida around. Sometimes there is a missing vertebrae. A missing vertebrae. As you pass your hand down, you see that there may be a hole at a point. So you identify all these as an abnormality, and then you take note of that. So when you reach here, you take the opportunity to open up the anus to look out for its patency. Whether it is patent or not, you ask the mother, please, has your baby passed? This one is a dry cotton. I want to use one to clean the anus. If I see any greenish something around, it tells me that the baby had already passed meconium, which tells us that the anus is patent. It's not blocked. It's not covered or occluded. So when we are done, then we want to measure the chest circumference and then the full length of the baby. So with the chest circumference, I lift this baby a little, place the tape measure under the baby, and then roll it to the center. Okay. This one I had 35. Then let's also do the full length of the baby. So the full length starts from the occipital area to, so I push. Okay. And then you stretch it. So when you reach here,
Can
you
let
leave
the
it,
head?
and then you come and then continue to the heel. So with the heel, I had 44. And because we are examining this baby, we want to be a little bit faster to prevent the baby from cold. Oh, okay. So now we want to tackle some of the reflexes of the baby as we examine. This is the neurologic examination of the baby before I come and then do the cord. So we have the glabellar reflex. With the glabellar reflex, when you tap the frontal head, the baby will frown the face, frowning of the face. That tells you that this baby is reacting to whatever is applied here. Is like a stimulus, a stimuli. So this baby will react, and the reaction will give you that type of frowning face. That tells you that this baby is active. If you place your hand there, you tap here, and you tap here, and this baby will not frown, it means that this baby is like non-reacting, will not react to any stimulus that comes. Then we have the routine reflex. Okay, when you pass, it's like you want to go closer to the eye. You see that the baby will blink the eye, wanting to, yes, react to whatever is trying to drop on the eye. And so it will blink, telling you that this baby's eyes, both eyes are also active. And then if you place, maybe you tap the corner of the mouth, you see that this baby will turn the mouth to wherever, if it is the breast, yes, it's trying to focus on that side. That is the routine reflex. And then if you put the breast into the baby's mouth, if baby grasps it or holds it with a strong something that it begins to suckle, that means that this baby is active. If you place the breast into the mouth and the baby just even want to bring the breast, the nipple out of the mouth, it's not ready for any breastfeeding. And so as you continue to examine the baby all around, you identify wherever the problem, if the baby has any problem, you will see. And then the grasping one, you place your hand into the baby's palm. You see that this baby will try to grasp you or hold up your hand. That one is also telling you that this baby is active. Then you have what we call the dancing or the stepping reflex. If you hold the baby and then it's like you try to put the baby on a firm surface, you see that this baby is trying to make a move. It will turn like it's making a step forward or backwards. That tells you that this baby, the limbs are very, very active and there are no problems with them. And so these are some of the things that the Barbican type, when you stroke or you give a strike into the feet or the sole of the feet, you see that this baby, when you strike it, it will try to pull the toe upwards and inwards, and the other ones will also stretch out. That means that this baby is reacting to that striking thing as a stimulus. It will react. And so it's telling you that this baby is active. And so there are so many of the reflexes which you can also find out, and then so that we can apply it whenever we are examining our baby. All right. And so when we are done, I'm coming to examine care for the cord. Care for the cord. Some areas they use the clohexidine and then the methylated spirit. We have the methylated spirit. We don't have the clohexidine. You just apply it on the cord, the base, and then on the cord. With the methylated spirit, we use it to clean and then leave it dry, as we also use that one of the clohexidine also dry. And so we'll use this baby for the cord dressing. Okay. So like I said, because I observed the cord and the cord was not bleeding. If the cord were to be bleeding, I would have applied another clamp under the first one to give it a firmer grip to stop the bleeding. But this cord is not bleeding. And so I'm just going straight forward to do the dressing of the cord. So when we finish up with the cord dressing, then we dress the baby, give the baby to the mother to breastfeed. So you hold cord with one cutting. And 5 centimeters away. Yes. So it goes this way. Okay. Then another cutting from the base to under the clamp. And another one from the base to under the clamp. And another one to clean the tip. This one we clean over here and then remove it. So basically I used about 6 cord clamps. Actually, you can use more than that depending on the state. Sometimes you see some black spots around here. So you can use more than what is required to do the cleaning. As far as the cord becomes clean, but you must make sure that at least 5 swabs would be used, but more than that can also be used. Sometimes you pick one, it may fall. So if you take the 5 and then some once you pick it and then it falls down, it means that you are lost and missed. You don't know what to do, whether to call somebody to help you or what. So you take extra. If you don't use or you don't lose, it's better than taking 5 and then you may use more than the 5. And that is when you may even decide to then separate some of the cuttings off so that you can get more to do the cleaning as we want to. So basically, this is the examination of the newborn, finishing it up. And so over here, when you are done, you place the diaper below the clamp so that the clamp, the heat will not affect the clamp to cause any fungi growth to bring about an infection. Okay. So basically, this is examining the newborn before, immediate and subsequent, before the baby goes home. It's very, very necessary and then important to do that. Once it is done, you'll be able to identify anything and then you help this baby go home in a very comfortable situation with the mother, and then the parents would all feel very, very, very comfortable. And so if you have any question, you can then ask. Any question that is baffling you, you can ask. And we can also ask you some questions. Examining the newborn is very crucial. So I'm dressing the baby. Anybody's hand up?
So no, what the heck is when you
Yeah.
mute?
Hello, sister.
Ask to unmute.
Hello, sister.
Rebecca.
Somebody's hand is up.
Please,
Wow.
good morning.
She has.
Please, my sister was measuring the head circumference. I saw that the baby's
Lizzie,
hair
take it.
cap is
You
on.
take this one.
I have one.
You have
So
one.
I want to
And
know,
answer. Hello. Yes. Sister Rebecca.
measuring the fetal head now. We should be putting on the cap before measuring, or we should measure before put on the cap.
Okay. Please
And
come
my
again. Your
second
question.
question is
No, your
about
first
the
question.
chest circumference.
Please.
Sister, please. I said that I saw sister putting on the cap before doing the head circumference.
Oh,
So I want to know, if we are doing the head circumference now, cover the head before, or we should do the head circumference before covering the head with the cap?
No,
And my second question is the chest circumference.
Mm.
In our antenatal book and our the book we give to the clients and our what do you call it? Our Form A, no. The chest circumference is not in.
Mm.
So I want to know if it is not good to do it or not, because me, I've been doing it, but I use a pen to write the chest circumference and put the figure there. But in the book, it is not part.
Okay. The chest, so far as the chest circumference is not in the book, doesn't mean that it's not required of a midwife to do it. You are supposed to do it. It's part of your responsibility, so that you can detect any abnormality from normal. You see that whatever we do on the ward, it's not everything that is
In the book.
Yes, in the book. So you have to note this. You have to measure the chest circumference, and as you said earlier, you use your pen to write. And with the hair circumference, you have to remove the cap. I think it skipped hair. Yes, so you have to remove the cap before you measure the hair circumference. The cap shouldn't be on whilst you are measuring the head circumference.
Oh, I push it back. Oh,
Okay. Oh, mom says she put it back.
I push it back.
Okay, sister.
Okay.
And please, the normal range for the head circumference and the chest circumference, please.
Okay. The normal range for the head circumference and chest circumference. Depends. This one I heard about is between 40 to 45.
That would be normal.
And the chest,
It depends on the baby. Some babies are very broad.
can
even get about, this one I had 30, a normal baby. This one I had 34. 34. So between 35, thereabout is normal. Some babies also have very small chests, which may be around 20. So you can see the differences. For example, a preterm baby has a very small chest range.
Please, did you hear? I hope you heard what mom said.
Yes, sister.
Okay.
Yes, sister.
Should come Sister, please. We didn't. Yeah.
Please come again.
Because your head circumference was 38. That's why we are asking.
Okay. Mom said you should come again. With the head circumference and the chest circumference.
Hello. Hello.
Hi.
You said,
Hi.
yeah. I said the head circumference actually depends. You have very big babies like a macrosomic baby, and the head circumference could be, in fact, the normal one maybe between 40 to 45. If you have a hydrocephalus baby, the head circumference would be more than 50. And so if you know the normal, and then with preterm and then small babies, their head circumference could also be less than 40. So it doesn't, it's not a strong point to say that the normal one should be this, but it depends on the weight of the baby. Some babies are very big, and once the baby is big, the head may also expand a little. That doesn't make it an abnormal. But if you see a hydrocephalus baby, you can identify that this baby actually has a problem. The head is big. And so it varies. It varies. But then the normal between 40 to 45, you can say yes, is within the normal range. Any other points?
Yet to have without this.
Madam,
Hello.
please, during the examination too, I realized the glove hand that was used to examine the head was same glove hand that was used to pat the mouth to rectify if the hard palate and lower palate are united. I don't know whether it's the right way or you need to change another glove to do that.
You don't
Because
need to
this
change
one is now going
another
inside.
glove. You don't need to change
Okay.
another glove. Otherwise, you use about 6 gloves before you finish the examination. Then, actually, you can even use a bare hand if the baby is bad. You can use your bare hand without using the glove. And once you handle the baby, you see that you cannot finish the head, go and wash, and then come back and do the mouth, go and wash, come back and do the abdomen, go and wash, and come back and do the perineal area. You see?
Okay.
So that one. Okay, so that one, nobody will penalize you for using the same glove to examine, and then when you reach the mouth, you use it that way too.
Okay. Thank
How
you.
do you do it on the ward? How do you do it on the ward? You are laughing.
Usually in the
How do you do it? You want to face reality. How do you do it on the ward?
Yeah,
maybe-
usually the same, but
Uh-huh.
I usually think because like if it comes out immediately and you are doing those examinations, maybe the mother perineal side would have been like infected with a lot of things. So changing that glove to examine, though we've cleaned the baby, but it's not everything can go out. So using that same glove going into the mouth, I usually have the perception that we can equally introduce infection to
Into
the baby.
baby.
That's why I'm just
Asking.
That's why
Okay.
I'm asking to clarify.
To clarify. Okay.
Yes.
So when we give you baby examination, what will you do? You would want to
I
change.
will now follow these steps.
Maybe there will be a change in future from you. You see, that's why you are talking. You can do a lot of research on this. There are so many areas that you can do a lot of research to come out with something. When you are done with your BSc, it doesn't mean that you are done. No, that's why you are being introduced into research work. And it calls for research can be done in any small area that can come up very big in future to help others. You see, so we are bringing out the points, but you may also have another point where you can also work out and then come out with something new, which will be very, very important. Thank you for your question.
Thank you, sister. Thank you too.
You're welcome.
So you meet one, you meet one and
Call that name for me.
no, Rebecca has spoken. Call Priscilla or
Elizabeth.
okay.
Hello, Elizabeth.
I've asked to unmute, but they haven't unmuted yet.
Ma.
Hello, Elizabeth.
Please.
You spoken?
Yes, ma. Yes, please.
Oh,
no,
okay.
I've not spoken. I'm yet to speak.
Okay, so now you can come up.
My question is like when you get to the lower extremities and you are to examine the genitals. So like if the baby hasn't passed urine, how will you know during your examination that the genital the urethra is patent or not?
That's why I said,
Yes,
when the baby is a male, you push the prepuce backwards, and then you look at the tip, whether the urethra is open. Or sometimes it's not there, it may be epispardia or hypospardia. So whether the opening is under the penis or above it. That is where you will see. But if the prepuce is covering the whole thing and you just hold the prepuce together with the penis, you may not identify where the opening is coming from, or it's not there at all. And then if it's a female, that's why I said you part to look at the clitoris. You know, the urethra is below the clitoris. And so once you part, you definitely see the opening over there, and then the labia majora, and then the minora. And so you see, in fact, passing urine, the important thing is to note whether there is the opening. But you know, the meconium one is normally very, very important, because you want to see that the rectum is, or the anus is patent. When you open up, you will see. Formerly, we were using our little finger to enter, but now we don't do that. And so you can use a cotton and then clean. One day, somebody said that if you don't do that, you realize that, oh, this baby is passing feces. The baby may have something like a fistula, which is, then it could be genital fistula coming from the vagina. You may note that, yes, this baby is passing the meconium, but not knowing the anus is occluded, but the feces is coming out from the vagina. That's why you part over there, you part here, and to be clear that all these areas, the opening is very, very clear over there. With the urine, you know, the more the baby takes in the breast milk, that one will help us to identify if this baby is passing urine or not. That's why postpartum, first 3 days, if the woman comes to see the midwife, these are some of the questions that you ask. Has the baby been passing feces? Has the baby urinating? How many times of your diaper have you changed if the baby soaks? And so sometimes before the baby goes home, once she's with the mother on the bed, we can still do that identification or verification from the mother, so that before she goes, we would have maybe, that's why I said, once we do the immediate one and then the subsequent one, so that we'll be able to identify any abnormality or congenital abnormality that maybe has come up. Have I satisfied your question?
Let's go Rafiat.
Any more questions?
Hello, ma'am.
Hello.
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 Please, please, with the chest circumference, I wanted to find out, like, the essence of it, like if we measure it and it's outside the normal or beyond the normal. What are the indications? And also, I was a bit distracted when you were examining the genitals. Please, do you examine the vulva before the anus or the anus before the vulva? Thank you.
I did the examination of the genitals before I went to the rectum. You know, the last thing I did was the checking of the vertebrae. And so when I was done with the back, then that was when I did the anus.
Okay, ma. Thank you.
And then you said if the chest circumference is too small
or too big, what does it indicate?
The indication I already mentioned that we may have a macrosomic baby, whose chest circumference and the head circumference could be above the normal. And then if the chest circumference also is very small or very, very little, that could also, you know, babies who are small for dates, they would have this small chest and the rest. That's why they will come for checkups, and then we encourage the woman to do a lot of breastfeeding to look out for if there is no abnormality specifically with the system. That one, once the baby may be smallish already. So with a smallish baby, definitely the chest circumference will be smaller. For example, if you have a baby whose birth weight is about 2.2, definitely this baby is small. And so anything about her definitely will be very small. And then you have a baby with a weight of 4.5 or 5 kilos. Compared to this baby, you see a vast difference. And so it doesn't make the one with the small chest an abnormal baby. And this one also will not make the one with a broad chest also an abnormal baby. And so we do it as a formality, and then also to help rule out any abnormality. You can write it in mother's ANC book for future reference also. Once it is there, then when the woman comes to, let's say she comes to ANC, oh yes, my baby's per the midwife's observation, your last baby's weight was small. Why? What happened? Or your last baby's weight was big. Or do you deliver big babies? She may tell you, yes, my babies are big. And so that one is not a problem at all. Yeah. And I think above all, the reflexes that we were talking about is important, because if a baby is big, you carry out some of these reflexes and the baby doesn't respond to the stimulus that you are giving, then neurologically, then you can conclude that this baby is not fine. You refer. Apart from that, if you carry out the reflexes and still you realize that this baby is responding to the routine reflex, glabellar, suckling, is holding the breast very well and suckling, and all, yes, you don't have any problem or any cause to fear. Any other questions?
Please, my hand is up. Patience. Can I talk? Hello.
Yeah, you can talk.
Please, sorry, the head circumference something. No. And throughout my practice as a midwife, I've never measured a newborn baby head up to 40. I get within 33, 34, 35. So I'm a bit confused.
The normal, if a baby is even big, the head circumference could be 35.
Yes.
Okay. And what about a baby with, let's say, hydrocephalus?
With the head, you can get up like 38, 39, 40.
40.
Yes.
Okay.
38 and above.
38 and above.
Yes.
Okay.
And it's even in record. With a normal, no, 33 to 35.
Okay. Okay, thank you. Thank you
too. Okay.
Okay.
Sister.
Hello.
Sister, please, I also want to find out the ideal way of checking the baby's temperature during the first 60 minutes after it's being born. Whether we will use the electronic thermometer or we will use our hands to touch the forehead and then the soles of the feet. Thank you.
You said first 50 minutes.
First 60 minutes. Yes, please.
Yes,
Yes, within that.
within the that one you will not use the thermometer.
Yes, exactly.
That is the first that is the 1 minute after birth.
No, within 1 hour after birth.
The first 1 minute.
The first 1 hour of birth.
1 hour. 1 hour.
Yes, Mama.
If thermometer is around,
yes, that one you can use a thermometer. Because 1 hour the baby has been moved from the delivery room to another room. I don't know the setup of others may have the same area as delivery and then as the postnatal. So it may depend if the baby is moved from there to another area. However, 1 hour, I think we have to use the thermometer to check the temperature. And then, like you said, you can use the electronic type. Yes, it depends on what you have on the facility, because not everybody may even have that one. You may even have the mercury type. The mercury type of that is the mercury in glass. You can also use that one. So it depends on what you have on the facility. Or what have you been using? What have you been using at your facility, please?
She wanted to find out if within the first 1 hour you use your hand. The sole of the feet.
No. And they have to use the thermometer.
The thermometer. There is last one hand here.
Hello, sister. Good morning.
Morning.
Please, thank you for the lecture, but kindly go over the reflexes, please.
The reflexes.
Yes, please.
Okay. We talked
Thank
about
you.
the glabella. And with the glabella, it's the touching of the forehead of the baby. You may tap it with your hand. So I mentioned that we have the glabella. When you touch the forehead, you see that the baby may frown the face in response to that stimulus that is touching the baby. Okay. Sometimes the frowning of the forehead may be like vertical lines on the forehead in between the eyelids, eyebrow. You may see that one over there as a form of reacting to the stimulus. And then with the moral reflex, that is when you try to lift this baby up a little, and then the baby will startle, like it's afraid. And so that one is also a reactive something to the baby. When you try to lift the baby up, you see that it will open up the hands, the palms like this, and then it will be shaking. So that one is the moral reflex. Then I mentioned the dancing or the stepping. When you hold the baby up, and then the baby, hello?
Hi.
Okay.
Hello, sister.
And the baby will make
Hi,
a move.
sister.
Okay. The baby will try to make a move or a step in response to what you are doing to the baby. So that one is the stepping reflex. And then I mentioned the Barbicans. The Barbicans is like you when you give a stroke into the feet of the baby, then the baby will the big toe will be opened up, and then it's coming. Okay. That is the Barbicans. When you strike the sole, the sole of the feet, the baby will react by opening and then folding the other toes together. And then the routine one is when you touch the corner of the mouth with the breast or even with your hand. You see that the baby will turn to the corner, especially if it's the breast, then it will open up the mouth. Once it opens up the mouth and you put the breast into the mouth, when the baby holds and then begins to suckle, that means that the suckling reflex is also active and working. Okay. That's all. Okay. So if there are no questions, we will want to end up and then, or do you have any other question to ask? One question. Okay, whose hand is up? Oh, yeah. Latifa. Latifa, Sister Latifa.
Yes.
Your hand is up.
Sister, about the soul, no, I didn't hear, please.
About what? The soul? I said it's the Barbicans reflex. Babinski reflex. Okay. Another one. Okay.
Sister, please. Please. When coming to exam, you first have, when you are good and the cord is bleeding, do you do the cord dressing first before you come and do all the examination, or you still have to do your examination until you get there before?
Okay. No, that one becomes an emergency. If you open, when I undress the baby, I observe the baby completely before I covered and then started. If the cord, I mentioned that if the cord is bleeding, you apply a second cord below the first clamp and then dress the cord. In fact, that is an emergency. Once the cord is bleeding, you don't have to finish with all the examination before you come and attend to the cord. No. So that one, you have to do the cord dressing, clean, and then dry it very well. And then you come and continue with your assessment. Am I okay?
Yes, please. So meaning when you get there, you will not dress the cord again.
Yes,
because
you've already done it. Yes, you don't do it again. All right.
Please,
hello.
Concerning the yes, ma. Concerning the cord. So, like, if it's bleeding and then you reclamp, will you cut the first
No, you
one
don't.
out?
No, that one you don't cut. You leave it. Because if you clamp and cut the first one, and the baby the cord is still bleeding, that means that if you want to reapply another one, you see that you go to even the base. Are you getting the point?
Yeah.
Otherwise, if you
Yes,
have the strips, that one, the ligature or something, that one you can use it to do it. But then normally you reclamp, but you don't cut. That is normally what is done.
Okay.
Yeah.
All right, ma. Thank you.
You are welcome. I covered 12 minutes. There are some questions. Hello. Whose hand is up, please?
Please, ma. When are we to take the temperature using the palm of the hand and the soles of the feet.
That one, I mentioned that, we do the immediate check of the baby. Immediate assessment of the baby, that is the initial assessment. Before the subsequent one is where you are going to use the thermometer. How do you do it at your facility?
We use the thermometer directly after skin to skin. Then when we are coming to dress the baby, we check the temperature and everything, use the thermometer.
How many hours after skin to skin? 1 hour?
1 hour.
So that's what I mentioned. Or you are still not clear about that? Are you confused?
If thermometer is around, I don't think there is the need
to be using the hand.
Yes.
Oh,
To
yeah.
check the
temperature of the baby. That's all. So what is the normal temperature of the baby? Let me ask. Hello, the normal temperature of a newborn. The one who just spoke. Priscilla. Hello, Priscilla. Safwa.
Yes,
Hello,
sister.
Safwa. Your hand.
Yes,
What is
sister.
the normal temperature of the baby?
Please, the normal temperature is 36.5 to 37.4.
Okay.
Thank you.
Did you want to ask a question?
No, please. Just to answer that one.
But your hand was up.
You wanted to ask.
Okay, we've answered the question. Thank you very much.
Okay.
You are welcome.
Thank you.
So, in the absence of no question, we'll call it a day. To meet, God willing, next week. We'll finish it up with vaginal examination. Next week, God willing. Okay.
Okay, Mom. Sister.
Yes, we'll do.
Okay, sister.
That will be.
Okay.
Thanks so much.
Thank you, Mama.
You are most
God
welcome.
bless you.
God bless you.
God bless you.
God bless you. Thank you.
God bless you.
Check now for about 3 times. Now, if you are not sure, then you go with the team.
Oh, okay. Okay, you say. Okay. Ben.